today we're talking directly to you, the non-medical prescribers out there.
Yeah.
Understanding how medicines actually, work in the body is just so fundamental to prescribing safely and effectively. It's crucial stuff.
Absolutely essential.
So let's really get into that today.
Right. And our focus for this deep dive is going to be on pharmacokinetics.
Okay, pharmacokinetics. Before we dive right in, let's just orient ourselves. Pharmacology, the big picture, that's the science of drug actions, right? Helps us make good choices.
That's the umbrella term, yeah.
But the specific question we're tackling is, what actually happens to that pill or that injection after it enters the body? Where does it go? What does the body do to it?
Exactly. And that's pharmacokinetics in a nutshell.
Yeah.
It's the study of that journey: absorption, distribution, metabolism, and excretion. You'll often hear called ADME.
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 Yeah.
Got it. Absorption, distribution, metabolism, excretion. Those are our stages. Now, I often hear another term alongside this: pharmacodynamics. How do we keep those two straight? That's a really common point of confusion, but it's pretty distinct when you break it down. Pharmacokinetics, the ADME part, is what the body does to the drug.
Okay, body acting on the drug.
Yeah, how it gets absorbed, where it travels, how it's changed, how it gets kicked out. Pharmacodynamics, on the other hand, is what the drug does to the body.
Drug acting on the body.
Right. Its effects, how it interacts at the target site, like a key fitting into a lock. That's pharmacodynamics.
Yeah.
And related to all this is bioavailability, which basically tells you how much of the drug actually makes it into your bloodstream ready to work.
Okay, good distinction. Lock and key is dynamics, what the drug does. Today we're focused on the journey through the body kinetics, the ADME.
Precisely. Just the journey today.
Let's start at the beginning then. Step 1, absorption. What's happening?
Absorption is simply the drug moving from where you administered it, like the stomach if it's a pill, or the muscle if it's an injection, into the body's main circulation, the bloodstream.
The entry point.
The entry point, yeah.
And there are loads of ways drugs can get in, aren't there? Can you give us a few common ones?
Oh, absolutely. The route is super important for absorption. So you've got the most common oral swallowing a tablet, like aspirin.
Right.
Then there's enteral, maybe through a feeding tube directly into the gut. Rectal, like a suppository. Intranasal, like allergy sprays.
Mm-hmm.
Inhalation for asthma inhalers. Then more direct routes, like intramuscular, your flu shot. Subcutaneous, under the skin, like insulin. Transdermal patches on the skin. And, of course, intravenous AV, straight into the vein.
Wow, okay, quite a range. Now, something I hear a lot about, especially with those oral drugs, is the first pass effect. What's that about?
Ah, yes, the first pass effect. It's really critical for anything taken orally or enterally. See, when you swallow a drug, it gets absorbed from your gut, but it doesn't go straight into the main bloodstream.
Okay, where does it go first?
It takes a detour. It goes through the portal vein directly to the liver.
Mm-hmm.
And even before that, enzymes in the gut wall itself can start breaking the drug down. Then the liver, which is like the body's processing plant, has a whole load of enzymes that metabolize or break down that drug even further.
It gets hit twice, almost. Gut wall and then the liver.
Pretty much, yeah. Especially the liver. So what happens is a significant chunk of the active drug can be inactivated before it ever reaches the systemic circulation where it needs to go to work.
Which means less drug actually gets through to do its job.
Exactly. That's the first pass effect. It reduces the bioavailability of orally administered drugs.
And that must mean you have to give bigger doses orally sometimes.
Precisely. Oral doses often need to be higher compared to, say, an IV dose of the same drug to get the same effect. You might need multiple doses just to get enough active drug circulating.
Okay, that makes sense. So those other routes, patches, injections, IV, they avoid this.
Largely, yes. They bypass that initial trip through the liver. 5e gives you like 100% bioavailability instantly because it's right in the blood.
Right.
But, every route has trade-offs. Injections can hurt or risk infection.
Yeah.
Patches can be slow to absorb. Inhalers need good technique, the right particle size.
So it's always a balance.
Always a balance depending on the drug and the situation.
Okay, so the drug's been absorbed. It's in the bloodstream. What's next? Distribution.
That's stage 2, distribution. Now, the drug, having entered the circulation, starts spreading out into the body's fluids and tissues.
Getting where it needs to go.
Trying to, yes. But it's not an even spread.
Right. What controls where it goes and how fast?
Well, blood flow is a huge factor. Tissues with lots of blood vessels, lungs, kidneys, liver, brain, get the drug faster.
Makes sense.
Places with poorer blood supply, like fat tissue or bone, get it much slower. Think about trying to get an antibiotic to an infected toe. In someone with poor circulation from diabetes, it's harder for the drug to reach.
Yeah, I can see that.
And interestingly, drugs that love fat, lipophilic drugs, can build up in body fat, which might prolong their effects, especially in people with more adipose tissue.
So circulation is key. What else affects distribution?
Tissue characteristics themselves.
Mm-hmm.
Capillaries, those tiny blood vessels, aren't the same everywhere. In the liver and kidneys, they're leakier, letting drugs pass easily.
Okay.
But the brain is different. It has the blood-brain barrier.
Ah, yes, the BBB.
Exactly. It's very selective. The capillary junctions are super tight. Only drugs that are lipid-soluble, fatty, or have a specific transporter can get across easily.
Like a security checkpoint for the brain.
A very effective one. That's why some drugs, like certain antihistamines, make you drowsy, they can cross it. Others, designed for the body, can't get into the brain.
And what about protein binding? I've heard drugs can stick to proteins in the blood?
Yes, that's another critical piece. Many drugs bind to proteins in the plasma, mainly albumin. Now here's the key. Only the unbound or free drug is active.
Only the free drug.
Only the free drug can leave the bloodstream, get into tissues, and interact with receptors to have an effect. The portion bound to protein is essentially inactive, just traveling around.
So like passengers on a bus. Some are seated, bound, and can't get off. Others are standing free and ready to jump off at their stop.
That's a great analogy, exactly. And this binding can act like a reservoir, releasing the drug slowly. But if someone has low albumin, maybe due to malnutrition or liver disease, they'll have less protein to bind the drug.
Meaning more free drug.
Meaning more free active drug, which could increase the effect or risk of side effects. Also, different drugs can compete for those binding sites. If you give two drugs that both bind strongly, one might kick the other off.
Oh, increasing the free amount of that second drug.
Right. Like warfarin and aspirin, that interaction can increase bleeding risk because more free warfarin is suddenly available.
Complicated interactions there. What about the placenta during pregnancy? Is that like the blood-brain barrier?
It's another selective barrier, yes. The placental barrier regulates what passes between mother and fetus. Some drugs cross easily, others don't, but many can cross and potentially harm the developing fetus, which is why checking drug safety in pregnancy is absolutely vital.
Crucial. Okay, absorbed, distributed. Now, metabolism. This is where the body starts breaking the drug down.
Exactly. Metabolism, or biotransformation, is the body chemically changing the drug, usually to make it easier to get rid of.
And this links back to that first pass effect we talked about.
It does. The liver is the main player here. It's packed with enzymes designed to process foreign chemicals, including drugs.
The body's detox center.
In many ways, yes. Though sometimes metabolism actually activates a drug.
Oh, really? Interesting. So metabolism isn't always about deactivation.
Not always initially. Then comes phase 2, usually.
Yeah.
This involves sticking another molecule onto the drug, like glucuronide. This conjugation almost always makes the drug inactive and, importantly, more water-soluble.
Why is water-soluble important?
Because water-soluble things are much easier for the kidneys to filter out and excrete in urine. So phase 2 is often about tagging it for removal.
Got it. Phase I modifies, phase 2 tags for excretion. What influences how fast this metabolism happens?
Lots of things. The specific liver enzymes involved are key. You hear about cytochrome P450 or CYP enzymes a lot. They handle countless drugs.
Right, the CYPs.
Genetics play a role in how active your enzymes are. Also, enzyme induction can happen. Take a drug repeatedly, and your liver might make more of the enzyme that breaks it down.
Leading to tolerance. Needing more drug for the same effect.
Exactly. Like with some opioids. The opposite is enzyme inhibition, where one drug blocks the enzyme that breaks down another drug.
Uh-oh. That sounds like a setup for problems.
It can be. If drug A inhibits the enzyme for drug B levels can shoot up, causing toxicity. And sometimes drugs just compete if they use the same metabolic pathway. Like alcohol and sedatives, taking them together slows the metabolism of both, making the effects much stronger.
So many potential interactions just at the metabolism stage.
It's a huge area for consideration, and this all ties into a drug's half-life.
Define half-life for us again.
Half-life is the time it takes for the amount of drug in the body to decrease by 50%. It tells you about the duration of action and how often you need to dose.
So short half-life, dose more often. Long half-life, less often.
Generally, yes. And conditions affecting metabolism, like liver disease, can dramatically increase a drug's half-life because not being broken down as quickly. Furosemide, for example, normally has a half-life around 2 hours, but in severe liver disease, that can stretch out significantly.
Meaning it hangs around much longer.
Much longer, increasing risk if the dose isn't adjusted. That's why monitoring liver and kidney function is so important when prescribing. Pharmacists often play a key role here too, monitoring drug levels like warfarin or certain antibiotics.
Right, final stage, excretion, getting rid of the drug and its breakdown products.
Exactly. The body eliminating waste, including the drug and its metabolites.
And the main route out is?
The kidneys. By far the most important route for most drugs. Blood gets filtered, waste products, including water-soluble drugs and metabolites, get moved into urine and flushed out.
And kidney function is key here.
Absolutely critical. Kidney function naturally declines with age, and conditions like chronic kidney disease or even heart failure can significantly impair it. We measure things like serum creatinine or glomerular filtration rate.
Makes sense. Where else can drugs be excreted?
The liver plays a role in excretion too, not just metabolism. Some drugs and metabolites are transported into bile, which goes into the intestine. Some might get reabsorbed, but the rest goes out in the feces. So poor liver function affects this too. Minor routes include sweat, tears, saliva, even reproductive fluids, and importantly, breast milk.
Ah, yes. Implications for breastfeeding.
Huge implications. Many drugs can pass into breast milk and potentially affect the nursing infant. Always, always check reliable drug references if prescribing for someone who is breastfeeding.
Okay, we've journeyed through A, D, M, and E. Can you maybe give us a quick clinical example? Pull it all together for a non-medical prescriber facing a patient.
Sure. Let's keep it simple. Imagine you're thinking about an oral pain med for someone with, say, moderate pain. Knowing about absorption, you know it won't work instantly because it's oral, and that first-pass metabolism might reduce the amount getting through.
Right.
Now, if that patient tells you they have liver problems, you immediately think, okay, metabolism might be slower, the drug could stick around longer, maybe I need a lower dose or less frequent dosing. And if they also have kidney issues, you think about excretion. Okay, the drug or its metabolites might build up because they can't clear it properly.
So you might choose a different drug altogether, or adjust the dose even more.
Exactly. Your knowledge of ADME directly informs your drug choice, the dose, the frequency, and tells you what side effects or issues to monitor for based on that individual patient's physiology. It connects everything.
That really crystallizes it. Understanding this whole pharmacokinetic journey is absolutely foundational for safe prescribing.
It really is. The route you choose, the patient's age, their organ function, other drugs they're taking, it all feeds into how that specific drug will behave in that specific person.
So the message is clear. Always consider these ADME principles. Always look up the specifics for the drugs you're prescribing in reliable resources.
Couldn't say it better.
And maybe a final thought to leave our listeners with. Something to chew on.
Okay, how about this?